My name is Maria Cabanillas. I'm an endocrinologist by training. Call myself an oncologic endocrinologist because I treat essentially only thyroid cancer. And I work at MD Anderson Cancer Center in Houston. I've been there for about 20 years now. Today, I'm going to talk about anaplastic thyroid cancer. My specialty has been in the very advanced thyroid cancers. And hold on, I'm going to pause the share so I can see. Okay, Rick, you wanted to talk? You're muted. I'm allowing you to talk now. If you want to, since you raised your hand.
No, ma'am, I'm sorry. That was a mistake. I apologize.
Okay, I wasn't sure if you were the moderator, maybe, and wanted to take over.
I'm very interested in your presentation. Thank you for being here.
Thank you. Okay, so I'll start sharing again. So my interest, clinical and research interest, is in the advanced thyroid cancers. And so one of my areas of expertise is anaplastic thyroid cancer. And we actually have a group called FAST at MD Anderson, facilitating anaplastic specialized therapies. And we formed this group to try and better understand anaplastic thyroid cancer and to really facilitate patients getting in the system quickly and being evaluated quickly. And so a lot of what I'm presenting today is what we've actually learned from having this, this group who we've now treated hundreds of anaplastic thyroid cancer patients. So I'll go ahead and get started. In order to understand what anaplastic is, you need to understand where it comes from. So anaplastic thyroid cancer is actually derived from more well-differentiated thyroid cancers. So the papillaries, follicular thyroid cancers, Hürthle cell thyroid cancers. These cancers arise out of, usually because they have gained some type of mutation in a gene that causes the cancer to arise. When those tumors start to acquire more mutations, so they might start out, for example, with a BRAF mutation, but then as time passes, they can acquire new mutations such as TERT promoter mutation, P53. Then they become more aggressive. They can become less and less, they can start looking less and less like the parent cell from which they derived, right? And we call those poorly differentiated thyroid cancers, which is kind of an intermediate step. So it looks like it has some features of the parent cancer, right? Let's say papillary in this particular case. But it's not completely, doesn't have all those features that we define as papillary thyroid cancer. And then as time goes by, even more mutations can occur. And then you have a tumor, which is called an undifferentiated or anaplastic thyroid cancer, that looks nothing like the parent cell at all. It's lost all those features. We know that because the patient has a very large thyroid, we can identify that it's derived probably from a thyroid cancer, but we can't tell for sure. And so we have to do special tests to see if it's possibly derived from a thyroid cancer. But I think it's important to understand this in particular because what it showed us after treating many anaplastic patients is that these patients, anaplastic thyroid cancer is not one cancer. It is many different cancers because it's derived from other types of thyroid cancer. So you might have a patient who has a papillary derived and then a Hürthle cell derived, and they behave completely differently. So it's really not one disease on a molecular level, it's multiple diseases. Okay, so in terms of the clinical aspects of this, anaplastic thyroid cancer, it does have the worst prognosis of all the thyroid cancers. It's rare. We think there are about 1,000 cases in the United States per year, but that actually might be an underdiagnosis because because some may not be recognized as having anaplastic thyroid cancer. Most patients have tumors that can't really be removed, not meaningfully, meaning that if you leave a lot of tumor behind, anything other than microscopic tumor, you're probably not doing patient many favors, because leaving tumor behind you're just allowing that tumor to grow out of control and become very large again. So we don't usually take out tumors, where we call debulking, where we just take out part of the tumor. And we do not like to do laryngectomies on these patients. At least at this time, we don't feel that is a good strategy. Half of the patients at their time of diagnosis already have metastatic disease. Metastatic means that it's left the thyroid and it's now in other organs. And most patients are older. They usually have, problems that come with age, such as cardiac problems and whatnot. And so it's a very difficult tumor because of these different aspects, because they're usually quite advanced. You can't take them out. They're rare. And they're in older patients who tend to have lots of other problems, like as previous cancers, for example. The staging of anaplastic thyroid cancer, they're all stage 4 disease because they are such aggressive cancers. We have 3 categories of stage 4. There's stage 4A, B, and C. Essentially, A means that it's just in the thyroid. We almost never find these patients. We almost never identify them before surgery. Stage 4B means that it's outside of the thyroid, might be in lymph nodes, but those patients don't have metastatic disease outside of the neck. And then stage 4C is metastatic. Sorry about the dog. Okay, hopefully he'll stop. So in 2014, we made a really big leap of faith because we had established FAST, and we, one of the questions that we received actually from some of my coworkers was, what are you going to offer these people? Like, they can get surgery, radiation, chemotherapy at home, which was the standard of care. And I said, yes, but, we can offer clinical trials. And so we made this big leap of faith where we were going to actually open clinical trials that were mutation driven. So we were going to look at the mutations and determine whether we could find an adequate drug that matched that mutation. But we had a couple of problems. One is that it took a really long time to do mutation testing. It's quite slow. And we just didn't really know if this was going to work, but we were willing to try. Okay, so the actionable mutations that we know about today. So these are mutations where we have a drug that matches the mutation, a drug that inhibits this abnormality in the tumor. So the most common one is BRAF, and it's BRAF, specifically BRAF B600E, and we'll talk about that. And then there are some rare fusions, NTRK, RET, ALK, ROS fusions that we can see in anaplastic thyroid cancer that actually have drugs that match it. And then maybe TSC 1 and 2, which are exceedingly rare, probably even more rare than NTRK and RET fusions. Okay, so genotyping. This is basically mutation testing, but we wanted to figure out how to go really fast. So we have 2 tests, and this is important if you've been newly diagnosed with anaplastic thyroid cancer or you've never had your tumor tested. The first test is BRAF by immunohistochemistry. Essentially, it's just taking an unstained slide and staining it for BRAF to see if the patient has this mutation or not. And the second is liquid biopsy, which is essentially taking some blood from the patient. So it's just a blood stick, and looking to see if you can find DNA fragments, which tells us, which we can test for those genes. And these are fragments that are coming from the tumor and they're shed into your bloodstream. So BRAF by immunohistochemistry staining, or IHC, we can get results within 2 days at MD Anderson. Whereas with mutation testing the traditional way, it takes about 21 days at MD Anderson. And so that was a real advantage because our first trial after we established FAST was a BRAF mutated trial. And so we needed something that was going to identify these patients very quickly. Because if not, they'd get too sick and they wouldn't be able to go on trial. The disadvantage is that you only find out about BRAF, and some centers do not have the ability to stain these slides, and they have to send them out. So liquid biopsy, again, this is just testing for fragments of DNA in the circulation in the blood. So you don't need a biopsy for this, whereas with the BRAF staining, you do need tissue. The advantage is that it is shorter than the standard 21 days, so it takes about 11 to 14 days. But fusions, unfortunately, we don't pick up all the fusions that we need to. Right now, the test is not completely optimal for some of the tests that are out there. Okay, so let's talk about targeted therapy. This was the first trial that we did after establishing the FAST group at MD Anderson. This was a global trial looking at a BRAF inhibitor, dabrafenib, and a MEK inhibitor, trametinib. This was a publication based on 16 patients. It took a very long time to enroll these patients. You ask why 16 patients, and it was because patients had to be in optimal health. They had to, that PS is performance status, I apologize for that. They had to be able to swallow the pills whole. And so if you know, if you are an anaplastic thyroid cancer patient or know of an anaplastic thyroid cancer patient, you know that the ability to swallow is quite hampered by the fact that they have this tumor that's pressing on the esophagus. So these were some limitations that we had. But anyway, we saw a very good response rate, overall response, a response rate of 69%. That means that there was 30% tumor shrinkage, 30 or more tumor shrinkage in 69% of the patients. OS is overall survival. That was at 1 year, 80% of the patients were still alive. And these are the graphs that we show to just put it in a visual. So these are the patients that met the 30% tumor shrinkage. You can see one of them had complete regression. And so the majority of the patients having responses, and this is the time that they were on treatment. So you can see that these actually were quite durable because they were on for many, many weeks. That data has since been updated in an abstract of 28 patients. Response rate is still maintaining high with 2 complete responses. And the overall survival was, that's the median overall survival. So like where half of the patients are still alive. That is, was 20 months. Okay, so about 1 year and 8 months is what patients on average lived when they were on this clinical trial. And patients actually, when they got responses to the treatment, they felt much better. That's what the patient-reported outcome scores are. So they, of course, if your tumor is shrinking in your neck and you're able to swallow and you're able to breathe better, then of course you're going to feel better. So this is an example of one of our patients with BRAF mutated anaplastic thyroid cancer, and I show this to you not to scare you. But this is a tumor that's coming out of the neck, but to show how quickly in just 4 weeks this tumor has regressed. So these are our most treatable cancers, the BRAF mutated ones. But the problem with these drugs is eventually these patients start to progress, so they start to outsmart the tumor. This is a patient of ours that had a very nice tumor shrinkage. This was her tumor on her scalp, went away, and then started to come back and then started to really get big. And so this is our biggest problem. So in order to somewhat deal with this problem that we know that eventually the drugs will stop working, we started removing these tumors. So you remember the lady I showed you whose tumor you couldn't even see it anymore on the outside of her body. And so what we do is that once the tumor is small enough, and if it's feasible, we take the patient to surgery and remove their primary tumor, because that's the tumor that's actually going to cause the biggest problems when the drugs no longer work. So if we can get it out, we feel like that will help the patient live longer. So we actually published this experience. You can see the publication there. This was just 6 patients. We've now done over, I think, 25 patients we've taken to surgery for this. And so in these 6 patients, they've done quite well. They're 83% of them were alive at 1 year, 62% alive at 18 months. We need better data, which, oh, here it is. Okay. So this is actually looking at a larger group of patients who went to surgery after being on a BRAF inhibitor versus the ones who were on a BRAF inhibitor but never went to surgery. So these are curves. These are Kaplan-Meier curves. Basically, for overall survival, you want to be up in this group because these patients lived much longer than these patients that didn't have surgery. So we think that this actually does really help patients. And this is our algorithm, which I'm not going to go through, but I show it to you because you can look it up in JAMA Oncology. It was published this year. And this is how we manage BRAF mutated anaplastic thyroid cancer at MD Anderson. So if you want to, discuss it with your physician, it's there. Okay, what do we do about patients who don't have a BRAF mutation? Because the BRAF mutation exists in about 40% of anaplastic thyroid cancer patients. And so that leaves 60% of patients without a really good treatment. So what do we do with those patients? Well, these are a little bit harder to deal with, but we do have some promising therapies. For patients who have fusions, so these are some gene fusions that we see in thyroid cancer, we see them in papillary, and we see them in poorly differentiated anaplastic thyroid cancer. They're very, very rare, but we see them. So patients who have a RET fusion, we actually have approved drugs. Some of you may know about selpercatinib, which is also called LOXO-292. This was approved for thyroid cancer with a RET fusion and for lung cancer. The other RET inhibitor, which is pralsetinib or Blue 667, is FDA approved only for lung with RET fusion. So, if you don't have a BRAF mutation and you don't have another mutation that explains where your cancer came from, we like to find out if there are fusions. And so this is the selpercatinib data. We published it in the New England Journal of Medicine. I think it was just last month. And this is looking at all the thyroid cancer patients with the non-medullary thyroid cancer patients. And you can see there were only 2 anaplastic thyroid cancer patients. Only one of the 2 had a response. It was actually a response for a long time, 18 plus months. But the other patient didn't respond. So we don't really understand this very well in anaplastic thyroid cancer. It seems to be a great treatment for papillary thyroid cancer, but not as good in anaplastic thyroid cancer, but we of course need more patients to really know this. NTRK fusions, if you have this fusion, there are 2 approved drugs, larotrectinib and entrectinib. They're both FDA approved for any kind of cancers that have an NTRK fusion. Larotrectinib has data in thyroid cancer, specifically in anaplastic thyroid cancer. And this was just presented at a meeting this year. And you see that the response rate is 29%. So that's pretty good for anaplastic, but it's nothing like the patients that had differentiated thyroid cancer. And again, the patients in orange are the anaplastic thyroid cancer patients. So we had some nice responses, but then there are patients that actually didn't have tumor shrinkage. And so it's unclear whether single agent drugs are really good for anaplastic thyroid cancer, right? With BRAF and trametinib, we had 2 drugs together. These are single agent drugs. We kind of feel like we need more than one drug in order to manage these patients effectively. So we need more research in that area. Okay, what if you don't have a BRAF mutation? You don't have a fusion. The more common mutations that we see in those patients is RAS and NF1. So then we look at, can we give a patient a drug that doesn't necessarily target a mutation, but targets kind of what the tumor needs to survive, which in this case with lenvatinib, it's a blood supply. So tumors start to to hijack your blood vessels, and they start to get all these blood vessels to the tumor so that they can continue to grow. And so lenvatinib, one of the ways that it causes tumor shrinkage is that it prunes away those blood vessels so that the tumor shrinks. And there was a study in Japan that looked very promising for lenvatinib. The response rate was 24%, which is not bad. 71% just had stable disease, but they all had some tumor shrinkage. And we opened a study in the United States to look at lenvatinib and anaplastic, and unfortunately, not very many patients responded. I think we actually had one response, and because of that, the study had to close early. And so we don't think that single agent lenvatinib is a good idea in anaplastic thyroid cancer. We're now doing a trial with lenvatinib plus immunotherapy. I just got word yesterday that the funding has come through. So we'll get started with that hopefully in the coming months at MD Anderson. So the question is, does targeted therapy really improve outcomes? Like, should we continue to pursue this? And the answer, we think, is yes. These are patients who are on targeted therapy. These are patients who are not on targeted therapy. So we do think that this is beneficial to patients, and but maybe not as just a single agent. So then we started to think, well, then what can we do to enhance those responses so the patients do better on targeted therapy when they don't have a BRAF mutation? And so we started looking at immunotherapy. Essentially, immunotherapy is teaching your immune system to fight your cancer. So instead of giving you a drug that targets the actual cancer, we're giving a drug that targets your immune system, ramps it up, and trains it to kill the tumor. And so the reason that we have to do this is because, in a normal immune system, right, your white blood cells here, this is a T cell, this is a form of white blood cells. They're supposed to recognize the tumor and get rid of it every day. It's supposed to be taking out those tumors, but for some reason that doesn't happen in some patients. And so what the reason it doesn't happen is because the tumor is giving signals out to your immune system saying, ignore me, I'm normal, I'm part of your body, and I should be here. And so we want to break that. We want to break those signals that are telling the immune system to ignore the tumor. So we do that with checkpoint inhibitors and other types of immunotherapy. You might recognize some of these names: nivolumab, pembrolizumab, atezolizumab, spartalizumab are all drugs that we are looking at in thyroid cancer. So we have one study of just immunotherapy called with spartalizumab, and this was a study that was also done globally. 42 anaplastic thyroid cancer patients. We saw some nice responses with this drug, and but only one response in 8 anaplastic thyroid cancer patients with BRAF mutation. So we don't recommend it for BRAF mutated patients as a single agent. What's really interesting is that if your tumor expressed something called PD-L1, and it's not something I can easily explain to you, but that's one of the signals that your tumor is sending out to the immune system. And if it's expressing that signal, right, the PD-L1, then what they saw was that patients actually lived longer if they were on immunotherapy. Makes sense because these drugs target PD-L1 and PD-1. And better responses. So then we started saying, well, okay, what if we know targeted therapy helps patients. We know that immunotherapy can help some patients. Why don't we put those together, right? Like Reese's peanut butter cups, for sure. Chocolate and peanut butter go really well together. We think that targeted therapy and immunotherapy also go well together. And so we saw a signal that some patients that had stopped responding to targeted therapy, we added immunotherapy, actually did quite well. Do we know if this is going to work as an upfront treatment? We don't know yet. We're doing the clinical trials to try and learn whether it is beneficial or not. This is our algorithm for how to manage patients that don't have a BRAF mutation and don't have a RET fusion, NTRK fusion, or any other fusions. And so again, this is something I'm not going to go through it. I just refer you to the publication. But really what we want is to put these patients on clinical trials, because that's how we got dabrafenib and trametinib for BRAF mutated. We would have never gotten that treatment had we not enrolled patients. Those brave 16 patients that went on that trial, essentially, or there were actually more, ended up being about 30 patients, were the reason that we have now this FDA-approved treatment. And so we need to continue enrolling to clinical trials. So in summary, I think it's critical to have mutation testing and PD-L1 staining on all patients who are diagnosed with anaplastic thyroid cancer. And if newly diagnosed patients should have very rapid BRAF testing, because we have very effective drugs. So we think that molecular targeted therapy plus immunotherapy is probably going to be a good therapy. Single agent immunotherapy might also be very beneficial in patients who express PD-L1, and you can have your tumor tested for that. Resistance is a real problem, and we continue to try and figure out how to get around resistance. And then again, participation in clinical trials is strongly encouraged. And so here I've just listed some clinical trials that might be of interest to you and their location. The first one is the atezolizumab, which is immunotherapy combined with targeted therapy. This one is available only at MD Anderson. Lenvatinib plus pembrolizumab, which I mentioned, we're going to be opening hopefully in the coming months. Also at MD Anderson, we're going to try and expand that out to a couple more centers, but it'll initially start at our center. Neoadjuvant, dabrafenib and trametinib. So neoadjuvant is basically shrinking the tumor first, and then with the inhibitors, and then taking the patient to surgery. We're combining this with immunotherapy. That's also starting in Houston. It hasn't opened yet, but we hope it's going to open in the coming months. Tumor infiltrating lymphocytes, I want to just very briefly touch upon that. So remember, I talked to you about your lymphocytes or your white blood cells, training them to take out the tumor. What this study is looking at is taking the tumor, removing the white blood cells, the immune cells that are there, called tumor infiltrating lymphocytes, and then growing those outside of the patient's body, making a lot of them, and then infusing them back into the patient to see if it will help destroy the tumor. And so we're also doing that in Houston at MD Anderson. Dabrafenib, trametinib plus radiation is, I believe it's open right now in Ohio State. An mTOR inhibitor called MLN0128 is open in Boston, Dana-Farber. And trametinib, which is one of the inhibitors that we use for BRAF mutated thyroid cancer. It's a MEK inhibitor plus cytotoxic chemotherapy, is open at Memorial Sloan Kettering. And then an anti-PD-1 drug, so one of these immunotherapy drugs, plus dabrafenib and trametinib in patients who stopped responding to dabrafenib and trametinib, is also open in Memorial Sloan Kettering. So there are other trials, and you can look on clinicaltrials.gov for these, but I just listed the ones that I think are really the most interesting to patients. And with that, I'm going to end. All right, well, thank you, everybody.
Thank you, Dr. Cabanillas.
You're welcome.
Always appreciate your time and your knowledge.